I'm just beginning the process. Had I had my simulation Tuesday. Tuesday as well.
Okay, everyone, why don't we get started? Hello there. Welcome to the Prostate Cafe. As the brochure states, we're here to field your questions. Okay, we're pretty good at most things prostate. I would like to thank the company that sponsored our breakfast this morning. It's a very interesting product. It's called Dendreon, is the company, and the product is called Provenge. And basically, we've been using a lot of it here. It's a targeted therapy. In essence, a patient has his blood drawn, and that's sent out to a specialty lab where antibodies are directed and sent back. And they're more specific to the cancer than, for example, chemotherapy. So it's a form of monoclonal antibodies. And the way it typically works is there are 3 infusions over the course of 1 month. And it's been very effective. It has some great data, and you can. Do we have some data on the Provenge? Do we have data on the Provenge, Andre? Okay, in the back.
I have a bunch of things right here.
You can pick up on it.
Yeah.
Also, there's information there about our supplements. They're interesting from the standpoint of being both USP and NSF approved. And so it's as good as they get, like a prescription med. Anyhow, without further ado, we opened here in 2001.
I was here.
And he was there. And one of our very first patients was Stewie. And he's our guest of honor today. So I'm going to open the floor to Stu for a few minutes.
Thank you. Well, welcome everybody. My name is Stewie Bitterman, and I'll just give you a brief story of my life. I was diagnosed with prostate cancer in 2001. My regular doctor said, calls me up and he said, Stu, he said, I don't like your PSA. It's 4.1, 4.2. I want to have you go to a urologist in town. Well, I didn't know Michael Dattoli from the hole in the wall. And I went to his urologist, his suggestion. And the doctor said, we're going to do a biopsy on you. We'll see how you make out. Had the biopsy, and I was home. I was living in Sarasota. He called me one day, 2 or 3 days later, and he says, Mr. Bitterman, this is Dr. So-and-so. You've got cancer. Well, let's go out and celebrate. What else are we going to do? And I, of course, I was in my 40s and scared shit. And made an appointment with him to see him. And it was almost like going to a used car dealer. Because he said to me, Mr. Bitterman, I just had a cancellation. I'm going to be able to get you in for your surgery within 2 weeks. And you're pretty lucky because most of my patients have to wait months. Some of them don't get a chance to get the operation. Well, we left SMH, Sarasota Memorial Hospital, which is where his office was. We're going down in the elevator, and I said to my wife, boy, this is going to be great. She says, just relax, okay? I don't know. I don't like this guy. I'm going to do some research. And this was in 2001 when we didn't have the internet like we have today. She found out that there was this guy. Stand up and say hello. We found this guy, and didn't know him from Adam. I called up the office here, and the girl said to me, sorry, sir. She said, Dr. Dattoli will not speak to you unless he sees you first, checks you out. Well, we came here, and that night, about 6 o'clock, 6:30 in evening, we're having dinner. Dr. Dattoli calls me. Spent better part of an hour and 15 minutes talking to me. I got up the phone, I said to my wife, I started to cry. I said, I gotta meet this guy and he's gotta save my life. And that was 21 years ago, and we've become great friends. We have dinner together. I help him as much as I can. And there's some great stories that, if you're interested, I'll tell you. My favorite story is Captain Mosher.
Mhm.
Captain Mosher was a Delta pilot who called me one day after I had my treatment here. And he said, Dr. Dattoli suggested I give you a call. My name is Rick Mosher. I live in Bradenton, Florida, which is the next town up from here. And I'm thinking of going to him. I said, can you give me some insights too? I said, sure. We spoke for half an hour. And he finally called me a couple of months later. He said, I started my treatment with Dr. Dattoli. I'm feeling great. I just wanted to thank you. Well, it was great. Well, now fast forward about 3 or 4 years later, my wife and I are on a plane going to Italy. And the captain gets on and he says, good afternoon, ladies and gentlemen. This is Captain Mosher speaking. How's everybody? We'll be flying at 35,000 square feet. Well, my wife gives me a jab. She says, Stewie, that's Captain Mosher. I said, who the hell is Captain Mosher? She said, you spoke to him. He was one of the Dr. Dattoli's customers, patients. Well, I took a little business card out. I wrote my name down. I said, Captain, I said, if you get a chance, please come and say hello to me. Came about an hour or two later, came out, and he said to everybody surrounding me, he said, I want you to meet Stu Bitterman. He saved my life. And he told the people around us his whole story about how he spoke to me. And the interesting story was that if he had had the operation, FAA would not allow him to fly anymore. But since he had the seating, and I think it was in his late 50s when he was treated, and he just retired a few years ago, just retired. But I'm here to help anybody I can here. I love this man. I love the practice. I love everything that he's doing. If anybody has any questions or if you'd like to tell me about what's going on with your lives.
Are you on this list?
What list is that?
That's the people that had treatment. No?
Yeah.
Yeah.
I should be.
Okay.
That was one of Dr. Dattoli's
Just so I can
patients.
contact you. Thank you.
Because he used to be in Tampa first, and he came down here back in 2001. Let me help anybody I can here. Anybody questions? Where is everybody in the treatment right now? Is anybody in treatment right now with Dr. Dattoli? You are? Where are you?
Radiation at 7 more.
You have 7 more.
7.
How are you feeling?
Good.
No issues?
Well, I think there's only one issue, and probably all of us have it. It's difficult to pee.
Yeah,
Part of it.
that'll go away.
And well,
It will.
I read about
Yeah, it will go away. But
it. I'm glad to be here too.
well, we're glad you're here.
I was somewhere else before I came here.
Oh, really?
Yeah, I was tickled to death when I got here.
You tickled to death.
Amen.
Did you ever hear of a patient saying that they're tickled to death because of their doctor?
No.
Anybody else I can help?
Thank you, Stu.
Thank you.
Okay, so who has questions for
I have one.
Yes, sir.
Is there any way to determine prostate cancer without a biopsy, or is that the only way?
Yeah, it is the only way.
Okay,
We have some very advanced imaging. Typically, before a patient comes here, they've even undergone multi-parametric MRI. And that could, radiologists have gotten really good at identifying prostate cancer. It was not that long ago, they can only say, well, I think there's a malignancy. But now they can not only say it's a malignancy, but they actually give a score to it. Not the Gleason score, but something we call PIRADS. And it goes from 1 to 5, with 1 being the potentially benign, 5 being as aggressive as it gets. So now they actually not only say there's a lesion, but they say it's going to be a PIRADS 4 or 5 or 3, whatever it might be. But a patient still needs a biopsy. Insurance companies won't allow us to treat you without a biopsy, because once a patient gets that MRI and they come here, we also do 3D color Doppler ultrasounds, which are very revealing of malignant, even more so than MRI, and I've published on that extensively. But the insurance companies say, oh, it doesn't matter if you found, the cancer in 2 different studies, the most advanced that we know of. They want still to have that biopsy. More recently, what we were doing with biopsies also was sending them for genomic profiling, which is a form of molecular biopsy, so to speak. But even that now, so that was a good reason to do a biopsy, because you could also determine the Gleason score. And again, Gleason goes from 1 to 10. 10's most aggressive. Most are around a 6. And but as you go from 6 to 10, they get more. It speaks for a more aggressive malignancy. But the same molecular profiling that we used to use on the tissue itself, the companies have gotten really good there too. And now they're doing what we call liquid biopsies. So they draw a blood sample, and that tells a whole story. So with molecular profiling, the things that are important could be that it demonstrates a specific mutation that suggests that you have a familial pattern. And for example, there's BRCA1, BRCA2 are these potential mutations. And in that situation, if it's positive, it's important for you, but it's also important for your family, because the same familial pattern is going to be a sibling's worry, a child's worry, not only for prostate cancer, but also for other malignancies such as breast cancer, ovarian cancer, pancreatic cancer, colon cancer, and melanoma. So that's a familial pattern that happens with that. So, but now we're doing most of those with liquid biopsy. So it's, when I say liquid, I mean just a blood draw. So also, since we're now in the age of targeting therapies, moving away from chemotherapies, which, for those of you who know about it, you get an infusion, and chemotherapy will, it kills your normal cells too, along with the cancer cells. It just happens to kill the cancer cells better because they're growing more quickly. But now with molecular profiling and targeted therapies, we're now using that. And, so more and more we're using immunotherapies. There's another group of drugs called PARP inhibitors, which are very specific for prostate cancer. So it's important. And some of those mutations also will predict which men will have a better response to hormones. So it's all important. Are there any other questions?
are there any natural, say, a diet, or what's good to eat for the prostate?
Right. So, what's good to eat for everyone from a cancer perspective and for a heart perspective would be the Mediterranean diet. And what Mediterranean diet really means is that it's fruits and vegetables. And you're allowed to eat meat, but that meat really shouldn't be red meat or pork. And pork is just as bad as red meat. And so that's the diet that the longest lived people in the world, the Mediterranean diet. There's 6 places around the world where people just live into, centurions. I mean, they live a really long time. And that coupled with activity, and that's an important element of it too, but that's a good diet. There has been data also for prostate cancer where dairy products are not a good thing. And we know that dairy is associated with increased risk for prostate cancer. But if you could, moderate or really lessen the intake of saturated fats in red meat and pork. Because what they do is things that are bad for us creates an inflammatory response in our bodies. And that's what saturated fats do. They create a body that's inflamed. And cancers like that body. They thrive in inflammation and other diseases too. So, heart disease is also follows the pattern of inflammation. And there's an interesting blood test. It's called C-reactive protein, and it tells your whole body inflammation. And it's a monitor of that. And that's a good thing you may want to get. You could tell your internists or primary care doctors to do it, because if it is high, then you do want to change your diet and see how low. You can get that C-reactive protein, also called CRP. So also, there are some supplements which appear to be beneficial for prostate cancer. There are some supplements also which make you pee better. And that would be something like saw palmetto and africanum pygem. There's a whole group of those. But the diet is very important with prostate cancer. And so if you got prostate cancer, or if you think you got it, or you have a family tendency to get it, then I do suggest low red meats and pork, low dairy consumption. And now we can get almond milk and oat milk and all those other good things, which you get used to, and you don't even really want to take milk anymore. So eggs are still, the jury is still out regarding eggs. Some think that it may have a little more inflammatory component in the yolk. The white is fine. The jury is out with respect to that. So anyhow, the longest lived people in the world. And, it's interesting because if you go abroad to Asia, they rarely get prostate cancer, and we think that's just because their diets, mostly fruits and vegetables. They do eat rice, but it doesn't seem to be a problem. Interestingly, when those same people relocate to the United States, by the time it's second generation, they're getting prostate cancer as frequently as we are, and breast cancer as well. So it really does have to do with our diets,
Thank you.
You're welcome. Anyone else?
What's your suggestions to the audience on supplements?
Well,
That was my question too.
okay, well, we like to, again, with cancers, you really want to bolster your immune system. So the supplements and vitamins that do that would be primarily vitamin C, zinc, and D3. D3 has also been linked to prostate cancer patients, and was very interesting because a long time ago, about 18 years ago, when the data first came out that prostate cancer is linked to vitamin D3, and that the more sunshine you got, the lower the incidence of prostate cancer. But what I did is I subjected all my patients to getting D3 tests, and guess what? They're really low. I mean, it was like a weird thing, because if I took another patient who didn't have prostate cancer, a male, his vitamin D3 seemed to be okay. But it was almost like a resistance. And many of my patients take increased doses of vitamin D3, upwards of 5,000 a day, and they still find a struggle to get that vitamin D3 to a normal range. But the immune vitamins are those three. There's another interesting one called quercetin, and that also has an immune response in our bodies. And then again, with prostate cancer, there's a dietary ingredient called lycopene, and you can get that in a supplement as well. And that's been identified to actually regress prostate cancer in the labs. And again, when we look at populations who eat a lot of tomatoes, which is where primary source of lycopenes, and most specifically cooked tomatoes, just have this powerful lycopene, and they actually regress cancers. So that's something I'd also recommend. Watermelons also have a lot of lycopene, and you can just go online and Google what has a lot of lycopene, because there are other things too. And then of course, there's the antioxidants. So turmeric, or the line of curcumin, it's really important. It's a powerful antioxidant, and it's also a powerful anti-inflammatory. So I'd recommend that as well. fish oil, for the same reason that Mediterranean diet and you can ingest fish and poultry and be healthy, the fish is really good, and it's the fish oil that tends to lessen our inflammatory response in our bodies. So it's wise to do that, and salmon is like one of the number one. But you could also take supplements, which is fish oil supplements, and it's interesting because most people don't. It's very healthy for many reasons: heart health, cognitive health. But many people, they don't realize is that when they open that bottle of fish oil, they got to put it in the refrigerator, otherwise it goes rancid. And that's really important because most people don't know that, and they have fish oil just hanging around, and it's not any good at all. Yeah, so it just doesn't do the benefit. So
Smells like dead fish.
those are the major vitamins. Now, here we have supplements. We obviously look specifically for prostate cancer, and cancer is by and large. There's other vitamins that are good, but
So,
yes,
as
sir.
I am getting ready to start treatment, was there any of these supplements that you'd recommend at this stage?
Yeah, I would definitely recommend vitamin D3, vitamin C,
What you mentioned.
yeah, and zinc.
Okay.
I didn't mention zinc. Zinc is another important, maybe the most important vitamin, okay, or supplement, just because, yeah, it has powerful immune response in the body. So anything that bolsters our immune system is a really good thing. For the same reason that, again, we're using more and more immunotherapies. Also, these days, when treating patients having prostate cancer, and if the prostate cancer is a more aggressive bent to it, at least an 8 through 10, there's a growing body of data which suggests that those patients do benefit from hormones in addition to the radiation. For a long time, we didn't quite know the reason why. And I often say, and you may have heard me say, that if you were to assign a benefit of radiation a unit of 1, then the hormones are a beneficial unit of 1, and you give them simultaneously, the 1 plus 1 doesn't equal 2, it equals 4 or 5 or 6. We call that a supra-additive event or a synergism. And again, for a long time, we didn't quite know exactly what was going on, because it's interesting that patients who do radiation and hormones, again, this is for high-risk disease, do better, okay, in terms of overall survival. And after that data came out, what happened with the surgeon said, okay, well, we're going to use 6 months, for example, of hormones up front before we do the removal of your prostate. And they did that, and there were numerous studies. And what they found initially was that, yes, the surgical outcomes were better. In other words, there were less, we call cut-throughs, meaning you're leaving less cancer behind, you're getting more negative margins. But as the years went by, the data just fell apart, and it seemed like it didn't benefit people who were getting, the surgery and hormones. And it may just be that it doesn't make a lot of sense. So surgery and chemotherapy does make your immune system decline significantly. Whereas both radiation and hormones, we call an upregulation of your immune system, so it bolsters that. These days, we're also using additional hormonal agents, which are called second-line hormonal agents. And there's 4 of them, almost 5, and they really peak the immune system. And so we like to use that simultaneously. Because by doing that, and we treat men who have disease that's advanced to bone and lymph nodes and things like that. And what happens is, if you can make that immune response very strong, then what can happen is, not only by treating the prostate, but the fact that you're treating the prostate and using hormones and the radiation, it actually has something we call an abscopal effect. An abscopal effect means that if you treat the primary site, prostate, and a person has lymph node spread or bone spread, they can actually wither. And you can review that in the literature as well. It's called the abscopal effect of radiation. And so there are some interesting side notes and pearls associated with radiation delivery. Yes, sir.
Oh, I'm scratching.
Oh, okay.
No, I had a
That's all
supplement
right.
question. Thank you.
That's all right. Yes.
How about miso broth? Is that indicated, while
I think
you're
it's
having
definitely
radiation?
beneficial. It's
Yeah.
definitely beneficial. Again, that's been identified to improve the immune response of your body. So yeah, it's a good idea. There was a time we didn't really want people to be on a lot of supplements or vitamins, but it's all changed now. Now we actually like for that to happen. The reason, and we also use some medications which are prescriptive, which brings more blood flow closer to cancer cells because radiation does work better in an oxygenated milieu. And so we do that now with a drug. It's very interesting called pentoxifylline, which actually improves the blood flow around the body, which is a healthy thing to do because as we age, what happens is our vessels kind of rescind from the parent organ. And that's what the aging process is. And that one drug can actually keep those vessels out there. And for the same reason, they could better oxygenate the cancer cells, which makes radiation work better. So most people here who have been treated by myself, you'll hear about that drug because we typically use it during the radiation treatment course.
I was on a watermelon diet. And unfortunately, it has lycopene.
Sure.
Sure enough, I read it's got the highest incidence of pesticides, that and kale. And I was eating both.
Yes.
Honey,
I know. I know.
and I love watermelon. I love it, and it was.
I know.
I'm doing a lot of tomatoes, just like you said, the cooked tomatoes, and it's.
Yeah, cooked tomatoes are a powerful source of lycopenes.
It's.
Yeah.
I just thought.
Yeah, I get it. I know that's the problem with many things, like the good fish. They're going to have the mercuries, and any fish that's been out there living for a long time is not a good fish. And that's why like salmon's good because salmon just goes upstream and dies, and that's where they catch the salmon, and unless
Don't eat shark or swordfish. That's
for the same reason they have high with mercury and other metallics, just because they live a long time.
Right.
So it's always wise to look at with fish which ones don't live a long time, and those are typically the most beneficial fish.
Yeah, I have a chart on the fish.
You do? That's interesting. I've never seen that chart.
I'll make a copy and leave it for that.
Sure, yeah, that'd be good. I'd like to see that. Mhm. So, any other questions?
Someone else mentioned, and it happens with me too, trouble urinating. It's becoming more painful and very frustrating.
Yeah,
Especially for me, like the last 2 weeks, I've noticed a very steady decline.
our patients treated here will find that on the menu. We usually check it, recommend it. But yeah, what happens with prostate is the prostate's a small organ, but it can grow really big. And when it grows big, it then compresses the bladder on top of it and the urethra, which runs right down the middle. So, there's a pipe, and so prostate is an organ that sits like this, and it's got the prostate urethra, which is the pipe that you pee through. And there's a big sphincter, a big valve here, and that's attached to the bladder, which is bigger. And what happens with prostate cancers is they tend to cause the growing here, even the weight of the volume coming in, it compresses this pipe. And so now you got to push it through a really narrow canal. That's
what causes the pain.
That's what causes, yeah. So and when you have pain, it usually means that it's also causing this big sphincter, this big valve, to be bothered. And because this is a really big muscle, we call it the internal sphincter of the bladder, which interestingly is removed at the time of surgery, but you don't want it to be removed. This is a really important valve that we have to control our urine. There is another group of sphincters below. There's another group of sphincters down here. They're called the external sphincters, but this one is, 20 times as big as this one. So you're really relying on this. But when you get compression of that by an enlarged prostate gland or by cancer, then it does annoy the heck out of this valve, and that's what causes pain. And sometimes that pain is felt down at the tip of the penis. It's called referred pain. So the two things that happen, as I say, are it can pinch off the prostate urethra, or it can grow here and cause the bladder muscle to be affected adversely.
They used to do a lot of trimming of prostate. I don't know what the procedure is called. I mean, that was rampant 20, 30, 40 years. Is that still going on?
It is. It's still going on. We're we encourage it only in certain people, but what you're referring to, it's called a TURP, transurethral resection of the prostate. And what happens is you go up here and then bore it out. And a TURP would actually bore out some of this big sphincter and even some of this part of the urethra. So that when we look at a TURP with our scans, we see that there's a void, a defect here, here, here. The problem with a formal TURP, and I don't recommend it, is several-fold. It's a bloody procedure, and there's been documentation that it could actually disseminate prostate cancer. And so what we typically do here is reserve that unless we absolutely need to have a TURP. But there's another procedure which is called vaporization. And with vaporization, you get a lot less bleeding, and it's just fast healing because you're no longer opening a wound. And so that's what we recommend if it's going to be done. And we only do that if we absolutely have to. And I work with some urologists who are really good at that. In the urology group in town and myself have published on that. It's on the wall over there in terms of how we did that. Because we only, again, sometimes patients can have a lot of urinary symptoms, and they may just get better with the radiation treatment. And we say, you know, hold off. We know you're having urinary bother, but maybe you don't need to have another procedure. So that we reserve it for the people who just don't benefit and they're just getting more and more miserable, because sometimes the radiation also causes inflammation. And so it could, you know, in and of itself cause a little bit of a reduced flow. And those patients that and also there's a sign that I see, again, when we do our imaging, we see that there might be a part of the bladder directly protruding into the valve. And it may be a benign component, and typically is. And so that would be an area that could be vaporized. And patients derive a lot of benefit from that. They really do. So when it's needed, it works. There you go. There you go. Exactly. Yes. You want to just tell your quick story? All right, never mind. Never mind. Okay, so anyhow, though, anyhow, it is effective, and again, you know, we reserve it, but when it's necessary, it's necessary. And I typically like to do it after a certain dose of DART. And the reason I do it that way is that if that happens, and there's, as I was saying, a TURP can disperse cancer cells, but if there's been a certain dose of the radiation we deliver here called DART, then it's basically has made the cancer cells null and void for a while. So that even if there were some cancer cells dispersed by the procedure, and there's not much with the vaporization, but if there was, they're just not viable. They can't really do any harm to you. And so that's the reason why we like to have it done only if necessary and after a certain dose of the radiation we deliver here, which is called DART. Yeah.
Thank you.
You're welcome.
I have a question.
Yes.
Can untreated prostate cancer be passed on to a woman during sex?
Good question. No, it cannot. It absolutely cannot. Yeah, it really, it can only affect the host. You know, that's it. You can't, you know, unlike some viruses and bacteria, you can't pass cancer along. Never been documented to happen.
Really?
That's a really good question. Yeah, yeah. Mm-hmm. We've gotten really good at imaging now. We were actually better though. In 2018, you know, we were doing a really interesting study here with nanoparticles, and it was started at Harvard, and we were working with Dr. Hermanzani at Harvard. There they called it Combidex, and then we took off with another agent called ferriheme, and they were ultra small superparamagnetic ferrous oxide nanoparticles, and it was amazing how much information we got from that in terms of cancer dispersion of prostate. Unfortunately, it's a long story, but you know, it just didn't fly with insurance after a while. We did it. We had a 10-year run here between 2008 and 2018. There's nothing like it. It did give me, though, an interesting glean that I probably never would have had it, and that is just how common prostate cancer likes to go to these regional lymph nodes. You know, we have these lymph nodes strewn throughout our pelvis and actually throughout our body, and And lymph nodes are basically scavengers. They're there to remove things that are not supposed to be there. So they'll remove an inflammatory pocket, they'll remove an infectious pocket, but they also perceive cancers as being foreign. And so they're going to grab cancer. And with the prostate, the prostate, I've often talked about this, it's a capsulous organ. So it doesn't have a big rind, like a lemon or a lime has its rind. It doesn't have any at all. And so while cancers do this easily, they also do that easily. And for that reason, these lymph nodes, which are tiny little dots, are often affected with prostate cancer. And, up until we were doing nanoparticle studies, I honestly didn't know just how common it was for these lymph nodes to be affected in the pelvic area and sometimes even higher up. But what commonly happens with prostate is that it'll affect the very nearby, the real close lymph nodes, and then it's kind of a ladder. And the ladder goes all the way up and ends up through our abdomen and actually into the chest area. And we occasionally see people with lymphatic spread all the way up to the chest area. We actually have some good results treating them too, but it has to be really precise radiation because when you start treating larger volumes, it's all about precision to minimize side effects. So, but anyhow, lymph nodes, really important. And, I even found that a sizable number of patients having Gleason 6 cancers, which is the most common that's considered not so aggressive, can have lymph nodes spread already. And I think that's part and parcel with prostate not having a capsule. But most cancers of the prostate do start on the edge and then they kind of work their way out with the tissues around them microscopically. There is another test now, it's called PSMA PET scan, and that had to take over for the nanoparticles here. And it's another test that looks specifically for something called prostate-specific membrane antigen. And with it, we can also pick up cancer in lymph nodes and FAR. In liver and lung and bones and things like that. And so it's not quite the nanoparticle test, but it's as good as we have right now. I was working with University of Michigan back in 2015 when they were up and running with the PSMA, and we had several men who had both tests, PSMA PET scan and the nanoparticle, and the nanoparticle was better. But again, we have to rely on it. Here we rely on many imaging guided tools. One is the PSMA PET scan. The other is we typically have patients get MRIs before treatment, and then we also do a 3D color Doppler ultrasound, and that's unique to this center. There are very few in the country, in the world. There's one in New York, there's one in Los Angeles, and there's one in Munich, Germany. We all know who we are, and it's really a really unique test, and we can see so much with our color flow Doppler ultrasounds here. And it also aids me because if I know there's a tumor here, those areas can get higher doses. So what we typically do is look at the prostate with our 3D Doppler ultrasounds, then we freeze everything, download it, send it to the treatment planning center. So everything is coordinated. Our radiation dart treatment with where the cancer is by Doppler ultrasound, but also our brachytherapy, the seed implantation, is also coordinated with where the Doppler shows the cancer. We rely on that heavily. And in fact, I've done studies where we've looked at all the different imaging tools to find when patients are having biopsies. And we were spot on. Like the 3D Doppler ultrasound shows an abnormality, it's in all likelihood a positive site of the prostate. And Doppler ultrasound is a way of looking a little differently at cancers than MRIs or CAT scans. It looks specifically for vascular patterns. And cancers create this web. They like to have lots of vessels to feed them and be nourished. And it's separate from your body. It's, what we typically look for is independent vessels in the prostate that just aren't supposed to be there. And then we know it's a cancer because it's just not supposed to be there. It's very interesting. There are very few places in our bodies that don't have a cardiac rhythm, and just about every place you could monitor your eye or even the lens of your eye, it's going to have some cardiac rhythm to it, but cancers have no cardiac rhythm. They're growing independently. That's what they do, and that's what makes them so bad. They have nothing to do with the rest of the body. So anyhow, but we like some really advanced imaging here. We actually have we just got 2 brand new imaging color Doppler ultrasounds, and they're going to soon. GE is putting on a pack on them, which will be the first ultrasound unit to have AI. So that's going to be really something. And we're told that's coming, within the next year, and they've granted us the approval. We know that we've already paid for it. So as soon as it comes, we'll have it, and that's going to be really interesting. Yes.
What is that gonna do that one that you have now doesn't?
Well, it remains to be seen.
Oh,
Okay, I mean, we'll see, because right now we see everything. One of the things will be really fast, we're told, is that right now, for those of you who have been treated here and have undergone ultrasounds, with the ultrasound guided method of finding how large is your prostate, we put an ultrasound probe up into the rectum and then take serial sections through the prostate going down. Each section is circled, and then the computer algorithm puts together the total volume. That's how we do it now. I'm told that with the AI, you basically put the probe and it automatically right away tells you the size of the prostate gland within 2%. So that's really interesting. Yeah.
thank you.
So but as far as cancer detection and that remains to be seen. But we'll be looking at it.
Does cancer always spread up in the body? Like you say, it started at the prostate, and then does it go up to the lungs and the brain?
With prostate cancer, it typically does. So as it pertains to lymph node spread, though. So what happens is there's 2 forms of spread of prostate cancer. One is through the lymph nodes, and if they start here, they move up. So, 6 months ago, this lymph node may not have been affected by cancer that was sitting down here, but as time goes on, it'll march its way up to the bladder. And that brings you up into the abdomen region, and eventually it'll go to your lymph nodes in the chest area. Yeah, we're loaded with lymph nodes in our chest. The other way prostate cancer is disseminated is just through the blood. And prostate cancers are very vascular. It's a highly vascular organ, prostate itself. And because of that, it could actually cause dissemination. Now, that may take a lot longer to happen than the lymph node spread. So I think lymph node happens really quickly. And from here, it's almost like it has to sit around in the lymph nodes for a while, and it may disperse it into the bloodstream after a while when there's a certain volume. The other things that we're always worried about is what I told you earlier, and that is, when you have a TURP procedure of the prostate, it's called a roto-rooter. We don't like them. I don't like anyone getting a roto-rooter because it does disperse a lot of blood, and with it can carry cancer and can go throughout the body. Biopsies of the prostate can also do that. So it's kind of a double-edged sword. So, you had asked if you can treat without biopsying, and, it would be nice because you wouldn't have that potential risk of dispersing cancer, but we try to do biopsies here, which are different. So we do know that the biopsies that happen through the rectum, it's called transrectal ultrasound guided biopsies, you engage a lot of the vessels from the rectum, which have an easy path to go everywhere else in your body, liver, lung, bones. And you can just see that in patients who have colorectal cancer. For example, rectal cancer is, unlike prostate, it doesn't hang around long. It shoots out, and that's because of the vascularity of the rectum. So we like staying away from the rectum when we do biopsies here, so as to not skirt cancers. We do it in a way we call transperineally, which is the area between your scrotum and the anus. A small area, it doesn't have a lot of nerve endings either. So it's pretty painless. And that's how we like to do our biopsies. And there's less blood spillage as well. And if there is blood spillage, it's more of a closed loop. It's not dispersion into the bloodstream by the rectum, by the rectal vessels. So, anyway. Yes, sir.
In the past, they said PSA was not recommended as a common test for males to diagnose prostate cancer. Has that changed? Are we still doing PSAs in the volume that we were? And the situation is, how do we how do we help that out?
Yes.
For the diagnosis of prostate cancer?
Sure. So interestingly, what happened here in the United States is in 2012, there was a task force, and they basically said, you know what, you don't need to get a PSA. And, you know, we don't care, you know, maybe you should get it because you have a first degree relative who has it, but all you other guys out there don't need them. And I knew that was wrong. And I was actually part of that task force at the time, and I voted against that. But, you know, the majority won. And for a long time, the doctors or internists, primary care doctors, they were let off the hook because they were getting sued right and left too. Because remember, if they forgot to get a PSA, and then next follow-up, they found the PSA was really high, and then they didn't have a benchmark to say, well, it was lower. They didn't have that information. So there was a lot of lawsuits launched because of that. So when the National Cancer Force said it's not necessary, they just dropped it like a hot potato. What has happened based on that is that there was a recent study looking at cancers in the United States from 2001 to 2019. And they found virtually every cancer incidence, prevalence, and death rate was on the down. That was a great thing. One exception, prostate. So prostate was being identified to be more aggressive, identified more locally advanced, and or metastatic to the liver, lung, bone. So my hope is that everyone is paying attention to that and, you know, being more diligent about getting PSAs, because it's still the best test we have. There is no other test for any other cancer that is as accurate as prostate cancer, PSA, prostatic specific antigen. It always was the best, it's still the best. And far as monitoring prostate cancer, we also like it because after treatment, you know, PSAs typically go down very low, and then we just track it. And sometimes, well, most times it stays low forevermore. Sometimes it may creep up, but it's not so important. It may be a very low value. Because after all, patients who's been treated to the prostate, they still have intact prostate. So it can also still make some PSA. So it's not that alarming to us. But anyway.
What's the cutoff? When do you start looking at the PSA? I know it's 4 usually,
Yes.
but the issue comes up is I tend to think that it's age related. The older you are, the higher the PSA normally. And should there be a graded PSA? And on another situation is, if most of us have prostate cancer in here, if we have children, we need to, if our PSA is up, we need to make sure that our children get tested. When should that be? Because usually it's 50 years old or older. But should, you know, your child, male, need to be tested at 45 or 40? Because there are prostate cancers that develop at that age.
Yes. Okay, so yeah, good questions. So in terms of the age, it's not so clear, but what I typically recommend is if you have first degree relatives who have prostate cancer or a mother who has breast or ovarian cancer, then I would strongly recommend PSA at age 40 and every year thereafter. Okay, that's what I recommend. And the PSA is still the best thing we have, but it's not so, the total value may not be as important as the rate of the rise. So a lot of patients I see, their PSAs aren't, and that just puts the 4 number, which has been universally accepted and historical for a very long period of time. Not anymore. Now we do look at how quickly it rises. And if there's a trend upwards, I spoke to a gentleman yesterday, I think his PSA was 1.2, but he had 3 family members who had prostate cancer. And it's been every single time he gets it, it's up another 0.1. It's only made it to 0.2, but you know, there's probably going to be something brewing because again, if you just look at the trajectory of the PSA, it's most consistent with malignancy. Also, men who have higher grade prostate cancers, what happens is as cancers mutate and become more aggressive, they are not even obliged to make PSA. So a lot of times when you start getting into those really high Gleason scores, again, we think Gleason 8 through 10's very high number. they start lessening the amount of PSA that they make. And so we've got to pay attention to that because, you know, again, I've seen men with really low PSA, 0.8, 1.2, with metastases around the body. And that could be because they have these really high Gleason score aggressive PSAs. If you just think about it, the better acting prostate cancer resembles the normal prostate cell more. The normal prostate cell makes PSA 2. That's the reason why as we get older, our prostates get bigger, PSAs go up. Okay, so we have to pay mind to, though, other factors, and that is the rate of the rise and the fact that as those PSAs go up and then actually plateau. In fact, when I follow men with active surveillance, meaning we're just watching his cancer, okay, what happens is the PSA is trending up, and it's when it plateaus that it gets my attention, because then I think it's mutating. And a mutated cancer does not make a lot of PSA, or it doesn't have to make a lot of PSA. So, you know, there's a lot to it. And so, you know, your garden variety Gleason 6s, maybe 7s are making more of the PSA, and the Gleason 8, 9s, 10s aren't. As you get to a 10, it really makes very, very little PSA. There's another blood marker called a PAP, and I've published extensively on that as being even more important for prostate cancer in terms of outcomes and prognosis. And we do use that in our patients here. Any other questions? Oh, yeah. Okay, well, that will conclude our meeting today.
Thank you.
Thank you for coming.